Good afternoon, everyone, and welcome to the second Healthcare-Associated Infection webinar presented by the New England QIN-QIO. My name is Carol Dietz, and I am the hospital HAI lead for the state of Connecticut. Along with me are my hospital HAI reduction partners from our other New England states. From Rhode Island, Maureen Marcella. From Massachusetts, Denise Selfridge. From Vermont, Regina Ann Cooper. From Maine, Danielle Hersey. And from New Hampshire, Margaret Crowley. We all welcome you and thank you for joining us. This webinar will be recorded and the presentation will be available within a few business days after the webinar. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines right now will be on mute for the duration of the presentation. Please do not put us on hold to answer another call. Music is very distracting. We will take questions at the end, and I will provide you with instructions how to unmute your line at that time. I am pleased to introduce today's guest speaker, Dr. Alina Filozov. She is a physician with Middlesex Hospital in Middletown, Connecticut, where she is also the chair of the antibiotic subcommittee, a collaborator in the creation of the hospital's fecal transplantation program, and she is also working towards developing an official antibiotic stewardship at the hospital. Dr. Filozov regularly attends the monthly Middletown Readmission Community of Care meetings to update the community members on the work being done by the Antimicrobial Stewardship Committee, and also to help the community implement interventions which will aid in the reduction of readmissions within all settings related to the care of patients being transferred with a history of an infectious disease. Dr. Filozov is certified by the American Board of Internal Medicine and the American Board of Infectious Diseases. She graduated from the New York College of Osteopathic Medicine and completed her internal medicine residency training at Westchester Medical Center and fellowship training in infectious disease at Montefiore Medical Center. Without further ado, I would like to turn the presentation to Dr. Filozov.
Thank you, Carol. Thank you, Claudine, for inviting me today to speak, and thank you everyone that joined us today, because this is a very important topic to discuss. The topic of this presentation is C. diff, but I will start by talking about antibiotic resistance, because these two subjects are very interrelated, and especially these days, the resistance is making news for everyone now around the country. So I think it's important for all of us to be aware of what's going on right now. As with all therapeutic modalities, antibiotic therapy would like to minimize unintended consequences while optimizing therapeutic effect. And even though we have a lot of the antibiotics that are used in our hospitals, some authors report that up to 50% of those antibiotics that are used are inappropriately used. Either the duration of those antibiotics is inappropriate, or the treatment is unnecessary altogether, or the coverage is too broad. And in addition to things that we take by mouth, by prescription, we're also bombarded by exposure that we get in food, in our water supply, by the antibiotics that inadvertently get into our system. How does it affect all of us? It affects all of us as healthcare providers, as patients, whether you are in an outpatient facility, in a hospital, in an extended care facility, in a rehab place, because inappropriate antibiotic use leads to antimicrobial resistance, and one of the examples of that is C. diff, which is also called collateral damage. So this is those unintended consequences that we would like to avoid. And there is a real human cost to this problem. I mean, it sounds okay on paper, but there is a human cost. When patients spend longer time in the hospital, their recovery is prolonged, they're dissatisfied with their care, and some of them actually die as a result of these infections. And I can tell you, as a medical provider, we are also unsatisfied with the care that we provide if one of our patients is not doing well, is not having the outcome we intend. And then there is a financial cost to this problem. There is an increase in admissions and readmissions to the hospitals and extended care facilities, and then ultimately it leads to financial penalties from different organizations and decreased reimbursements, which in these days is very important for all the hospitals, for all the facilities. So this is a simple diagram which shows how we come to this problem of resistance. When we are born, we're colonized with multitude of bacteria. In essence, we have more bacterial cells in our system than human cells. And with years of exposure to antibiotics, we are, by we I mean healthcare providers, are selecting for a group of bacteria that are very resistant and that ultimately lead the disease in us and also can be transferred to other patients. And those bacteria who are resistant, they're very friendly. They share their resistant profile with their relatives, as you can see here. So if E. coli has offspring, those can be sharing the same resistant profile. But also they can share with their neighbors. So if E. coli and Klebsiella is in the same neighborhood, they can all be sharing the genes that confer them resistant to maybe the same group of antibiotics. Fortunately, we have a lot of antibiotics over the years that are able to control a lot of these infections. And they affect certain parts of the bacterial structure. Either they affect cell wall, as it is the case with beta-lactam drugs and vancomycin, or they affect nucleic acid synthesis, or they affect the cell membrane integrity or certain metabolic pathways of protein synthesis. But unfortunately, every force needs counterforce, and the microorganisms are developing things to resist our ability to kill them. Certain microorganisms decrease permeability of their cells, so the antibiotic cannot actually enter the cell to cause harm. Certain microorganisms actually deactivate the drug when it gets inside the cell. Others change the drug target that we develop to cause the ultimate cell death. Or others actually actively pumping the drug out of the cell. And then the most resistant of the microorganisms employ more than one method of conferring resistance to our treatment. And then over the years, we are facing now with the soup of things that we don't want to see on our doorsteps, from MRSA to BRSA, to ESBLs, to CREs, to NDM metalloproteinases, to MAP1, which we're going to be discussing later today, and then very resistant TB. And as I tell my patients, if you see an infection that you have that is abbreviated or has a lot of numbers, it's never a good sign. So we are now stuck with all these things that we need help with in treatment. And it's not an issue of if, it's an issue of when. If you can see on the right side, this is when the antibiotics were introduced, and on the left side is when we see the resistance. So as an example, in the 60s, we introduced methicillin. In the 62, we already had MRSA. Or vancomycin, introduced in 1972. In 88, we already see vancomycin-resistant enterococcus. And in 2002, we see vancomycin-resistant staphylococcus. So it's just a matter of time before these things develop. And also another thing, that observation, as you can see from this table, we have less and less antibiotics being introduced in the past 20 years or so than before. So that's an additional problem. And back to the human impact of resistance, just having an R versus an S in an MRSA versus MSSA, or VRE versus VSE, or having a resistant versus sensitive Pseudomonas, or having very resistant Acinetobacter actually carries mortality risk. So you are more likely to die if you have one of those resistant bacteria. And all of us, in whatever healthcare settings we are, we're somewhat responsible to this vicious cycle of having these bacteria coming to our hands, to our facilities, going to the community, coming back to us. But of course, and unfortunately, this is only the tip of the iceberg. How many of us, our patients are colonized with resistant bacteria? We don't quite know, but this problem is probably much, much bigger than we anticipate. So CDC a few years ago came out with a group of microorganisms that require urgent attention, both from the pharmaceutical companies where we should develop certain therapeutics, or from the public as well, or in the healthcare facilities as well. One of them is C. diff, which causes up to 250,000 infections per year, 14,000 in deaths, and $1 million in healthcare costs. So these are huge numbers in terms of the patient cost and financial cost. And the other two things that we obviously keep on radar, which are not the topics of today's conversation, are CLEs and gonorrhea. So now to C. diff. This was discovered in 1935 in the stool of healthy infants who are seen healthy without any GI symptoms. And it is gram-positive, spore-forming anaerobic bacillus. What it means is this is a bacillus that can live in a can live in an environment without oxygen. It's gram-positive and a special staining, and it forms spores and produces toxin. What it means in terms of forming spores is it causes a hard shell, and it's become a vegetative type of state, bacteria, that can survive disinfectants, can withstand drying, can survive for months in the environment. And in this last point, you can see that in the room where the patient with C. diff was residing, it could be cultured up to 40 days if the cleaning was not appropriate. As we started with, we have a lot of bacteria in our stool, 10 to 11 per gram of stool. But all these bacteria are in some balance. It's a very fine balance. When we take antibiotics, this balance is disrupted, and it causes what's called dysbiosis. And that's what leads to C. diff. C. diff produces three different toxins. They're kind of related. So there are toxin A, which can be produced separately from toxin B. They can work both of these toxins together, or one after another, or certain bacteria can only have toxin B and not toxin A. And what happens is toxin B, when it works with toxin A, binds to the enterocytes, which line up the gut mucosa, and let toxin A come in and cause all this inflammatory reaction. In essence, both of these toxins can cause inflammatory reaction of the gut and causes death of the neutrophils, death of the enterocytes, and all of this causes pseudomembrane. But what became also clear in the late 90s that C. diff is producing a large toxin, which hasn't been really known to be produced by clostridial species, called binary toxin. This toxin is encoded by two genes, so it's one toxin that has two different components. The catalytic component for toxin A and a binding component for toxin B. It does the same thing, but the outcome is a hypervirulent strain, not one that we will be focusing on today. And this is just a simple diagram. You can see that toxin B enters, gets to the enterocytes, it binds, and toxin A gets in with a complicated inflammatory reaction with the inflammatory mediators, with neutrophils. It causes this conglomerate of dead mucosa, dead neutrophils that we call pseudomembrane. And that's how the pseudomembrane looks on a gross examination. It's this yellow membrane-like structure, but it's really this exudated structure that's as a result of the C. diff infection. So when we see patients with C. diff, on the CAT scan, we see this thickened bowel wall, which is inflamed and thickened. This is what the surgeon sees when they take a patient to surgery. This is when we have a last resort kind of effort to save the patient, when either part of the colon, and most of the time whole colon, is removed to save the patient. And this is what the pathologist sees. You can see that this is not a normal mucosa of the gut. This is covered by all this goo that is inflammatory, exudated, infiltrates from C. diff and other cells. Up until late 90s and early 2000s, C. diff was really not part of the conversation between healthcare providers. It was more like a nuisance. We knew that there were a couple of drugs that can cause diarrhea. The diarrhea would be self-limited. You would give somebody metronidazole or flagyl for a few days, and they would go, and the symptoms would go away, and the patient would never have recurrence. However, this paper from Quebec came out, and that really changed all our perception of C. diff. You can see in this particular hospital, in 91 and 92, they had 169 cases of C. diff, 5% of which died within 30 days of diagnosis, and 7% of which had really a complicated case. Now let's fast forward to 2003. They now have 390 cases of C. diff, 14% of which died within 30 days of diagnosis, and 18% had a complicated course. So this is a total game changer. We knew something is different about this C. diff. And if they look about the characteristics of the patients, There was really no major difference between female or male, but we noted that people were a bit older. Most of them had symptoms, at least in that paper, in the hospital. They had tube feedings. They were more immunosuppressed. They had more pronounced systemic illness with fever, with very high white blood cell count, and they were treated with by a variety of things, from metronidazole to vancomycin to a combination of both. And as I was saying, for years we thought, well, it must be the clindamycin, or it must be the cephalosporins. So this paper showed us it's not any none of any of them, it's all of them that can cause an infection. So if you look here, this is the clindamycin. Well, yes, it does cause C. diff, but if you can compare it to penicillin, cephalosporins, of different generation aminoglycosides, which are not very high on that list, and then this quinolone. And this really was the hallmark of when we discovered a quinolone-resistant C. diff strain. You could see how the order of how much higher the amount of cases is with quinolones. And that's when we come to this hypervirulent C. diff, which is called in full VI NEP1027, which stands for Restriction Enzyme Analysis VI North American Pulse Field Type 1, or PCR ribotype 027. So these are basically markers for research lab trying to identify this particular strain. And although this map is older, from 2007, by now most of the states in the country have reported these hypervirulent NAP strains of C. diff. And what the hallmark of this illness is increasing incidence, increasing severity, increasing recurrence, and increasing mortality. And just looking at the basic research, if you just look at the amount of toxin this particular C. diff strain produces, this is the regular C. diff, and this is the hypervirulent strain. You can see these are long increases in the toxin. So the mere, not only that the toxin itself is very complicated in structure, it also the amount of the toxin is much higher. And then what's new about this new C. diff epidemic is that it's now affecting populations that were thought to be much lower risk or lower risk in general. People like young adults, children, people who don't have traditional risk factors of hospitalization or antibiotic exposure. In this paper in 2012, there was 61% of the community-acquired C. diff was in the younger patients. And if they looked at 90 days before this onset, 22% had no antibiotics whatsoever. So this is already alarming. And then if you look at another group of patients where we don't really see C. diff, or at least did not see it in the past, is healthy women who just gave birth. So the baseline for MMWR is to report one state would report 3 cases of C. diff in 10 years. Between May and June of 2005, in this paper, there were reports of 10 cases from 4 states. So there is definitely something different about this C. diff. And we see it in terms of the rate of the hospital diagnosis. These are rapidly increasing numbers. We have patients with this diagnosis compared to all other diagnoses that may have increased slightly, but not to the same extent as C. diff. And if we look at our population, our older population is probably the highest risk patients. In this graph, the solid line represents over 65-year-olds. But this highest graph is the above 85-year-old patients. There is 201% increase in the rate of C. diff hospitalization in patients who are above 85 years old. And other organizations also report similar sort of results. So again, 85-year-olds and older, huge increase in cases, as well as 65 and 85 as well. So the older you get, it seems that the risk is highest as well. Now, in addition to the age, if you have a colitis already, with, as it is the case with inflammatory bowel disease, your risk is highest as well, higher. So if you compare people with non-inflammatory bowel disease, and these are patients with ulcerative colitis or Crohn's disease, you can see that ulcerative colitis seems to have the highest risk compared to the Crohn's disease. It's not just the incidence that is increasing, it's also the mortality that's increasing. Between 2000 and 2007, 400% increase in their deaths attributed specifically to C. diff is noted. So we said that age seems to be the risk factor. Hospitalization seems to be the risk factor. Antibiotic exposure seems to be the risk factor. Having a GI procedure or immunosuppression, either with inflammatory bowel disease or with another condition also, and having inflammatory bowel disease as well. And also more recently there were discussions about having indiscriminate use of antacids for many years after a patient no longer needs it can put patients at risk for not just community-acquired pneumonia but also for C. diff. Whether you are developing symptoms in the community, nursing home, hospital, we count all these cases, but there are also cases that have no explanation because these patients have no healthcare exposure. These patients may not have any antibiotic exposure too. So whatever the setting you are, if somebody presents with diarrhea or somebody develops diarrhea in the middle of whatever treatment they receive, it's very important to start a certain number of steps to limit the transmission of C. diff in the setting. Okay. In our hospital, we call it special contact precaution. We assume that somebody is wearing gloves, gowns, and using soap and water for washing their hands. So in your facility, it could be just contact precaution with a certain criteria for soap and water washing hands. We should send students for testing. We should stop all unnecessary antibiotics or change them to more gut-friendly options. And there are things that are less likely associated with C. diff than, let's say, quinolone or clindamycin. We should stop all anti-motility drugs. Those can provide short-term relief of symptoms, but long-term will increase the severity of illness. We should start treatment empirically even before we get the testing. And then depending on the severity of the illness, a lot of patients will have to be starting with NPO, and then they can be gradually introduced liquids, and then ultimately lactose-free, low residue, low fiber, low fat, with no caffeine kind of a diet. Very bland, but this is all temporary. And when patients have this kind of diarrhea, they're ready to do all kinds of free diet. Very important in regards to incontinent patients, and even young patients who are not previously incontinent, is to use barrier cream. These patients develop explosive diarrhea. They have no time to even run to the bathroom. And a lot of these patients may develop secondary infections. So to prevent that, barrier cream exposure to the perineum is very important. And then ultimately, whenever the patient is out of the room has to be cleaned appropriately with bleach-containing solutions. So the ideal is to place the patient in a private room. That's the very best. If it's not available, you can cohort the patient with another patient with C. diff. If you're in the middle of epidemic and you have no private rooms, you are not able to cohort, sometimes you can put the patient with another roommate who is immunocompetent, who will not share a bathroom, who will actually understand your directions, who does not have any high-risk things like indwelling catheters like IV, feeding tubes, or Foley catheter, and can follow direction and hygiene. And then we continue precautions until patient returns to his or her normal stooling pattern. We'll talk about it a little bit later because it's always a problem. Majority of people who recover from C. diff do not really have a normal stooling pattern. So it's a sort of a moving target. But it's a case-by-case discussion or, thinking about whether this particular patient is appropriate to stop isolation or not. Now we talk about testing. We have multiple testing, but I'm going to focus on things that are most commonly used. We all know about EIA. This is a very old test that we use all the time. It doesn't cost much. It has a turnaround fairly quick, less than 24 hours. The problem with the test, it has sensitivity as low as 60, but in some papers even lower than 60%, but high specificity. And this is the test that in our hospital, that test was present for a long time. There is also GVH test which has a good sensitivity, not as much specificity, also pretty quick and low cost. So each of them separate is not exactly as good of a test as we hope to, but a combination of both may be the best we could do compared to the PCR. PCR, of course, an ideal test for a lot of infections, including C. diff, but it's really cost prohibitive for a lot of institutions, hospitals, outpatient facilities. It has high cost, although it's a very quick test, very nice sensitivity, very good specificity. So if you can afford it, of course, that probably would be the test of choice. But in our hospital, we're using a two-step approach, a combination of checking GDH antigen and a toxin. What GDH is a special enzyme that is present on all C. diff organisms, whether they're toxigenic or non-toxigenic. So if we find GDH antigen and we find positive toxin, we have a confirmed result for confirmed C. diff illness. If we have a negative GDH and we have a negative toxin, there's a pretty good negative predictive value of this test. So a lot of times we can rule out this disease. But of course the problem is what to do with the gray area. And sometimes the gray areas are very common. It's when we have a positive GDH and a negative toxin. So the negative toxin can be considered falsely negative if the clinical status is suggestive of a true C. diff disease, or it could be truly negative. So people employ different methods. Depending on the risk patient, they can actually treat them as they have an actual C. diff, or they can repeat the test, or they can disregard the test. And these are the guidelines from 2010 about the treatment. If you notice, the metronidazole is only indicated in the initial episode of the mild or moderate. But more and more we're coming to the rescue of oral vancomycin because of unreliable results with metronidazole, even though it's really cost effective, speaking of prescription. I know a lot of my patients who have Medicare have very hard time obtaining oral vancomycin because it costs them hundreds and thousands of dollars. And when compared to vancomycin, metronidazole is not doing as good when we talk about severe C. diff. This paper is from 2007, but the same results were found in this 2005 paper, where there may be similar recurrences in both flagell and vancomycin, but the higher failure rates are associated with the flagell. So last year, this new drug came to market called Difficile. It's a macrolide antibiotic, which is similar to other macrolides like Zithromax, for example. It was indicated in adults. It's a course of 10 days of twice-a-day drug with not very significant side effects. If you take into account what the person who has C. diff has already, having a little bit more nausea, vomiting, and abdominal pain, frowning is not going to be noticed as much. But what they found is compared to the oral vancomycin in a double-blind randomized study, where patients with non-severe infection with either no history of recurrent C. diff or only had a prior episode, that when we talk about non-virulent, hypervirulent strain, not one, Difficile seem to do better with recurrences. But when we talk about NAP1, there is really no difference. So it's a good medication on the market. If insurance pays for it, it's great. It seems that 10 days should be enough for somebody who gets a first episode of C. diff. But when we're talking about a virulent NAP1 strain, it's probably not as good. And then back to the collateral damage. We are treating C. diff with metronidazole with oral vancomycin, and at the end, we are stuck with more dysbiosis in forms of VRE. So this is something that we have to watch for as well. So now we started thinking about, is there something else we could do in addition to antibiotics to help treat those patients with C. diff? Probiotics is a very popular topic these days. And there are multiple trials with multiple participants. The problem with these trials is each trial uses a different probiotic at a different strain from a different company for a different duration with a different antibiotic. So it's really hard to compare these. But the results are suggestive that it's probably helping somewhat, but to what extent it's unclear. Saccharomyces boulardii is one of those probiotics that seems to have a lot of good press lately. It was discovered by Henry Bullard when he saw that locals in Southeast Asia were chewing on the skin of the lychee and mangosteen to control symptoms of cholera. And when they took this fruit to the lab, they found that it seems to inhibit toxin A, mediated diarrhea and inflammation. It produces an enzyme that cleaves toxin and toxin receptors. It stimulates the inflammatory response to toxin A and inhibits the inflammatory response to the whole C. diff in general. And when they did animal studies, it seemed to improve the survival. In one of the only studies that I found, Saccharomyces boulardii compared, in addition to high-dose oral vancomycin, seemed to have led to a decrease in recurrence. But if you look at the guidelines from 2010, they're still saying there is no compelling evidence to support routine use of probiotics for prevention or treatment of C. diff. I'm hoping with the next guideline there may be some information, some data that can help us in that regard. Non-conventional treatments have been used some for years, some more recently. Vancomycin enema is something that we introduced probably in the past, I would say 7 to 9 years, where vancomycin oral solution is introduced through the enema, but I'm yet to see a successfully executed vancomycin enema. It's always very difficult for both the patient and the nurse to do that, although we have good results with some of our patients. And then we come to FMT, which we always were looking at to see whether this is going to be our final sort of last resort therapy. And it came about after in the veterinarians were using stool of healthy horses, and we're kind of introducing them into the intestines and the horses who have diarrhea, and they noted improvement. So now we are using that experience to try to treat our patients. If you look at these studies that are presented here, they're not large studies. They're between 1 patient and 40 patients, but they all have pretty good success, between 83% to 100%. And that success may be evident within several hours after the procedure. And FMT can be done by different methods. It can be done through the NG tube, through the enema, through the colonoscopy. In our hospital, we started the project with colonoscopy. And now we have FMT in a pill, which is getting a lot of pills excited, or a lot of patients excited. But it actually consists of multiple frozen pills that you have to swallow and hopefully keep down, which should be less cost prohibitive and should not be requiring a separate procedure or admission to the hospital for it. So that's all reassuring. The problem that medical community is having now, we don't know who is the good donor, who is the perfect donor. Not necessarily everybody who doesn't have C. diff. It could be other people. That's why NIH came up with this human microbiome project, where they're trying to understand gut microbiota. It seems that whether you live in Asia or in America, whether you're vegetarian or a meat eater, whether you take probiotics or antibiotics, whether your nutrition is perfect or not, whether you're young, older, or a little bit older, your microbiome is very different. And we don't know at this point whether we should match our elderly patients to the elderly donors, or we should match our elderly patients to a healthy donor. So this is the program that will help us really have a lot of answers, not just about C. diff, but also there's a lot of discussions about diabetes, obesity, and even intelligence, how this is connected to our microbiome. And then I put a plug in for our infectious disease department. Yes, you were right. There are 3 of us here. In patients who have serious infections, not necessarily C. diff, but including C. diff, people with HIV, patients with HIV, endocarditis, there seems to be a trend of improving survival and improving hospital readmissions if infectious disease is reviewing the case and following the patient. So don't forget your neighborhood infectious disease doctor. Now, a lot of patients and physicians come up with the question, do I need to retest stool? Do I need to do test of cure? The official answer is no. Patients may shed the toxin and the organism for several weeks after the treatment, and if they don't have diarrhea, the suspicion for C. diff is really low. So there is no reason to continue retesting patients for it. And then in addition, if you do find, for example, somebody with a presence of C. diff in their stool, these patients may be actually at the low risk for disease, not at the higher risk. In extended care facilities, there's always a problem what to do with patients who cannot stop having diarrhea. And if you look at the CDC definitions, they say you have to do it a case-by-case basis, balancing the risk of infections to other patients and impact on the infected patient himself. But in my experience, if somebody has a stable frequency of the stool without worsening, they are off therapy, they are not incontinent of stool, they're clinically stable, they don't have a fever, they don't have a high white blood cell count, they eat okay, you can consider stopping isolation. Again, this is case-by-case basis. So to sort of summarize what's been said so far, contact isolation, soap and water hand washing with the suspicion of C. diff, stopping all unnecessary antibiotics or changing them to C. diff friendly, start treatment for C. diff, avoid all antiperistaltics, aggressive fluid management, appropriate diet from NPO to liquids to the residue diet, and then consider consultation with ID. Now, is everything so gloom? Is anything can we do about this? Well, these two examples can show that we can. This is one of the, so both of them are outbreaks, and this is in France and this is in the U.S. And you could see that with infection control investigations, with initiation of staff training, with a proper and improved environmental cleaning, and initiation of antibiotic changes, we can control the epidemic. This happened here, look at the epidemic here, this happened here as well. So with just, they are not simple steps, but there are easy steps to do, we can make difference in our facilities. Of course, we cannot really have a great say in limiting use of antimicrobials in agriculture. We're too small of a we have individual providers trying to take up individual patients. We would like to have encouraged in development of the new treatments. We would like to have a national campaign, but what we actually physically can do is institute antibiotic stewardship programs in our hospitals, in our extended care facilities, and our outpatient facilities. And the goal of antibiotic stewardship is to optimize the benefit of the antibiotic treatment, which is very important and necessary to reduce the damage and the cost of cost. And to make it successful, we need strong infection prevention programs, we need rapid diagnostics and prompt treatments, we need people to have local antibiograms when they choose impaired treatments, we need to use antibiotics at the right dose, interval, and duration, and we need to stop them when it is appropriate. And speaking of infection control, hand hygiene, there is no argument these days that this is very important. When you see the patient, when you use the room, hand hygiene, whether you use soap and water in patients with suspected C. diff or hand sanitizer, it's very important. Vaccination. If somebody has lower risk of a viral infection, they have lower risk of a secondary bacterial infection. Hence, they will have lower risk of antibiotic needs, and hence that cycle of unnecessary use can be broken by that way. Now, we need to focus on environmental cleaning, and these days there are multiple companies doing all kinds of trials with hydrogen peroxide and UV lights and all kinds of things to try to eliminate C. diff or other multi-drug resistant organisms from the environment. We need to track and transmission of pathogens, and we need to have policies, whether infection control policies and hospital-wide policies to decrease the transmission. The antibiogram that I mentioned helps us to find susceptibility patterns when we choose empiric therapy. We see if the resistance shows unusual or worrisome trends, and we can start or have a plan of action. So we still have multiple challenges with C. diff. We need a better way to prevent C. diff in high-risk settings, like healthcare, like hospitals, like extended care facilities. We need rapid and accurate diagnostics, which is not price prohibitive. We want everybody to be able to have PCR, which is quick, precise, but we need to make sure that people can afford it, facilities can afford it. We need treatment options that are effective and they can prevent recurrences. We need better data on probiotic use. We need to know which probiotic, how long, which is the brand, how many millions or billions or gazillions of the probiotics we need to use and at what time. We lack in this data. And finally, we need the treatment of fulminant C. diff, which at this point we have really only colectomy, which is very dramatic and changes people's lives forever. So things that, again, I'm repeating myself, but these are things that are easy and simple to do, can really make a big impact in your facilities. Hand hygiene, avoiding all unnecessary antibiotics, and that's why I come to the community of care meetings on a monthly basis, where we try to educate everybody on dangers of antibiotics. We try to come up with algorithms where UTIs are not treated indiscriminately, where bacteriuria is not treated indiscriminately, which when every fever has a specific algorithm of workup. Fever doesn't equal antibiotics. Fever doesn't equal infection. So it's very important. Education is really important. We will continue, and I also would suggest that you guys do the same, where you work in terms of the UTIs, respiratory symptoms, and wound care. And always, you can question MD if necessary. If somebody gives antibiotics, you can suggest, maybe this is not the time, maybe we should wait, if you are the ones that are taking care of the patients often and know the problem at hand. In addition to these two, proper isolation methods are important, education is important, and again, don't hesitate to call ID, because sometimes even having a discussion about whether you should treat the CTI or not can limit that particular patient from unnecessary exposure. So in summary, antibiotics are a limited resource. They are overused, they lead to danger of antibacterial resistance and C. diff. C. diff reached epidemic scale and can be life-altering and life-threatening. And sometimes life-altering is as bad as life-threatening, as I see patients going into hospice care only because they have C. diff and they're elderly and they cannot really take care of themselves. Flagyl and oral vancomycin at this time are the mainstay of treatment, but FMT seems to be a groundbreaking option, which we need to learn more so we have it really very successful. And in addition to alternative methods, recently there have been articles about using colostrum from a hyperimmune cows who are pregnant, and that antibody-rich colostrum was used to treat piglets that had C. diff, and they had excellent results. So there may be something else on the market soon that can give hope, including C. diff vaccine, hopefully, if people are working on it. Again, proper isolation, limiting antibiotic use, hand washing programs will help staff, residents, decrease the risk of unexpected and unwanted complications. And remember, whether you are in a hospital, working in a hospital, whether you work in an outpatient facility, whether you do not work in a healthcare facility at all, we're all in it together. And we need to stop pretending this is not on our doorstep. It's between all of us. And I thank you for your attention.
Wow, thank you so much, Dr. Filozov. Every time I listen to your presentation, I learn something new. Oh my gosh, thank you so much. So at this time, we do have a few minutes for questions. So if you would like to ask a question, please press *6 on your phone to unmute your line. And before you ask your question, if you could please state your name and what state you're from, and then ask your question. Dr. Filozov would be glad to answer. So again, *6 to unmute your line. Well, I have a question for you, Dr. Filozov, while we're waiting. You are starting an antibiotic stewardship program at your hospital. What's the first step? Do you get the physicians together? Do you get the pharmacists together? What would be the first step for a hospital who should be at the table to start this initiative?
My first meeting is actually today after this meeting. And my first meeting is going to be with infection prevention nurse. We will set up our plan because there are so many things I want to do, but I don't want to do it all at once. We want to do things step by step. So she is the first person I'm going to be meeting today. I also will need very involved pharmacist who has interest in IV, who will be helping me monitoring the antibiotic use. I will also need an IT person, somebody who can help me develop certain order sets, help me limit the antibiotic use, help me educate, for example, the hospitals of when the antibiotics will be timing out, so the patient is not the first one of receiving antibiotics, but the physician is aware why we're stopping the antibiotics prematurely. There will also need to be buy-in from the hospitalist or the surgeons, anybody who is in a hospital who is using the system. The 3 infectious disease doctors will be integral part of this facility, and nothing can be done if there is no buy-in from the administration. So we had several meetings with several members of administration, and so we hopefully will have full support for them.
Excellent. Excellent. Great way to start. Okay, so anyone have any questions for Dr. Filozov? It's *6 to unmute your phone.
I have a question.
Okay, your name, please, and then state your question.
Celeste Jane Stebbins from Vermont.
Okay.
We've had a couple of employees, nurses, that have contracted C. diff. We have not been able to track it to inpatients that had C. diff. There was no connections that we could ascertain. But one of the questions that came up was, should nurses or healthcare workers wear shoe covers while they're as part of personal protective equipment when they are caring for C. diff patients? We do, of course, clean with bleach, but we don't generally mop the floor every day with bleach while the patient's in the room because of the fumes from bleach. So,
thank you for your question. I just want to clarify something. Are these nurses who actually do the cleaning of the room, or they're caretakers?
They're care providers.
Okay. Using boots on the shoes is not recommended to contract C. diff. It's a fecal-oral transmission, so it's through the hands and getting into your oral cavity. So having boots on the shoes will not really help. But I'm surprised that you have several nurses who have they not? Yes.
Not several nurses. We've had 1 or 2.
Okay. Okay. So those may be just isolated episodes unrelated to the patients they've been taking. But as I said in the beginning, we're all patients at one point or another. So there could have been an exposure to antibiotics from the outpatient, from some of those nurses, and they must be colonized with C. diff because they're taking care of multiple patients who may have had C. diff, and that's what was the trigger. It happens, as I said, sometimes you can find the reason, and sometimes, as in the community, there is no reason. Recently, I had a pregnant patient that had no exposure to antibiotics whatsoever, and she came down with C. diff. So it could be a coincidence that they're working on, I don't know if they're working on the same floor or a different floor, but they could have been exposed to antibiotics outside their work environment, and maybe they were at risk because they were colonized.
Okay, thank you.
Great question. Thank you. Anyone else? *6 to unmute your phone.
Hi, it's Maureen from Rhode Island.
Hi, Maureen.
Hello.
We were wondering about the usage of protein pump inhibitors. How do you feel about that?
There is more and more papers that are coming out that using proton pump inhibitors places patients with high risk of community-acquired pneumonia and also C. diff. That's a big task to tackle because at the same time as we see the negative press with PPIs, people who are critically ill need to be on PPIs to prevent other hospital-acquired issues like gastritis and GI bleeds, stress gastritis. So we would suggest, and as we do with all of our education reasons, that if somebody does not need a drug, whether it's a PPI, an antibiotic, or for that matter a blood pressure medication, they should not be on it. And I think taking care of the elderly patients is very important because as they go from one specialist to another specialist, things are just added to them, and they don't really have a good follow-up. So somebody actually takes things away. And as a rule of thumb, it seems that everybody who gets on a PPI never has them stop. So we are planning to work with our GI colleagues to discuss this very issue, to see who out of our hospitalized patients should not be on a PPI. Of course, we don't have to take away PPI from the ICU where people are really truly critically ill or somebody who's actually having GI bleed, but anybody else who has a mild reflux and can be without PPI, I think that would be reasonable for us to tackle that issue as well.
Thank you.
Excellent question. Thank you. We have time for about one more question. Star 6 to unmute your phone if you would like to ask a question.
This is Terry from Connecticut.
Hey, Terry.
Hi, Terry.
Hello. Great presentation. Thank you once again for sharing. My question is, if you have a patient in the hospital that's acutely ill and septic from C. difficile on pressors, is fecal transplant an option for that patient population?
Funny you ask. Just 2 weeks ago, we had a patient just like that who, without the transplant, would have died. This patient received fecal transplant as a sort of last resort because the only option was to take the person to OR, but we knew that the outcome would not be good. And this patient, as far as I know, is doing very well.
Excellent.
So, yes.
Wow.
It's not an approved entity, but when all our options are exhausted and when the life is on the line, sometimes you do things like that.
Wow. Excellent. So your hospital has started?
Yes.
Has started. Excellent. Thank you, Terry. That was a great question. Okay, our time is up. So, thank you for the great discussion. I just have a few last announcements before we end today's webinar. You will receive a follow-up email with a link to a very brief evaluation about today's webinar. We ask you that you please complete it. Your feedback is very important to help us to provide you with meaningful programs. Also, once you complete the evaluation, you will receive a certificate of participation also through an email. Within the next few business days, we will be sending out an email to everyone that has listened in today with instructions on how to access the presentation and the recording of this webinar for future listening. Thank you again for attending, and we hope you have a great day. And thank you again, Dr. Filozov. That was an excellent presentation.
Thank you, all of you, and thank you for your hard work.
Bye, everyone.
Bye, Charles. Thanks.
Bye. Thank you.
Okay, guys, you can pull up that evaluation on our side.